NICO trial came out late 2023. And that's a random dog. It's not my dog. And basically the effect of non-invasive airway management of comatose patients with acute poisoning. So gonna kind of go over the trial objectives, a little bit of history on GCS scoring, and then the review of the trial and kind of discussion between us. Main clinical question that they wanted to explore was in patients with suspected acute poisoning, GCS less than 9, can you do a conservative airway management strategy versus going for intubation? And is there an outcome difference between the two? And we'll kind of get there. So GCS, as we kind of all know and discussed multiple times in the ICU, developed in the kind of mid 1970s in a neurosurgical unit, and it as assessment of consciousness. It was primarily developed in the setting of brain traumas or subarachnoid hemorrhages, large stroke. But even in the paper itself, it extended itself to kind of more metabolic encephalopathies, even though that's not kind of where it came from. It was included in the advanced trauma life support guidelines in its initial stage, this first one in 1948. And then as it worked through its 80s, it became one of those 4 scores that we followed, like the Apache, Jabris, Ascot, and would be integrated in outcome studies. Largely, it's the common rhyme GCH of 8 intubation has basically become dogma throughout the years. Once your GCS drops below 8, you need to have some form of airway infection. Now, let's see if I talk about it. That's certainly true. They've shown that improves outcomes in the trauma setting, both in like traumatic brain population, preventing secondary injuries to the brain from either aspirations, pneumonias, or anything that helps with the recovery. I don't think that's not the question we were kind of asking here. But it's kind of more how well does that extend, or that dogma extend to the medical population? There are certain weaknesses that often cited. There's a large amount of inter-observer variability between GCS scoring, lack of evidence on approved outcomes in non-traumatic patients, and once again, maybe a bit of over-reliance, especially I think in the emergency room setting. I think they've looked at a couple of attending EMS professionals scoring patient GCS, and there's quite a bit of variability which come up with their final score. But I think like most of the time, people can look at it as just another clinical indicator and hopefully take in the patient itself as instead of just using it as a straight pattern indicator. So what was this population that they looked at? The decreased level of consciousness secondary to non-traumatic causes, specifically in acute poisoning. Acute poisoning, of course, was mostly alcohol-related, drug-related, or medication-related. And then some prior studies where they looked at these and these population, like there was a early 90s, there was a 12-month prospective study as a useful guideline for intubation, where they basically looked at ED physicians' evaluation of the patient. They GCS scored them, and it correlated well with GCS score less than 8, with the ED physicians would often be intubating these patients for airway infection. Then there was late 90s, there was a retrospective study of acute intoxications in 99, and found that patients not intubated for GCS less than 8 had episodes of aspiration. That was their outcomes that they looked at. And Then kind of in the late 2000s, in Scotland, they looked at more in the population where people are coming in acutely intoxicated from alcohol. Observation versus conservative care, you know, what were the outcomes with that? They found largely no major difference between the two. And the one patient that did end up getting intubated had the initial GCS of 12. So they were saying, okay, maybe that's not the best guideline. And then also around the same time, they were looking at acute poisoning in the organophosphate population and found that using GCS for airway protection reduced aspiration pneumonia risks. Now, in that study, they were doing decontamination with charcoal. So that was kind of their main driving thing. Hey, if we're going to decontaminate someone with low GCS, you should probably form some airway protection to reduce aspiration. It's just kind of pick and choose a couple, some cons. Yeah, that's Ben. My dog.
Hey, Ben.
Yes, Ben.
That's how I'm going to fill the child.
Also true. A little bit of buffering. All right. So the paper itself. Question, decreased level of consciousness, they may be at risk of aspiration and other secondary poor outcomes, necessitating the airway protection and the non-traumatic setting. Mentioned GCS as the indicator for intubation. It's been debated many times in the past, and they're trying to perform a prospective randomized control trial in order to answer that question. And that they say there's no previous studies with high level of evidence to guide management, so they created this study to look at it further. It was multi-center, multiple randomized and parallel groups, of course, unblinded because we can't blind intubation. And basically they were handed an envelope and blocks for the various areas in the country, whether they would tracheally intubate comatose patients with GCS less than 9 or just follow routine practice. Conducted around 21 sites, 20 ED locations and 1 ICU in France. Inclusion criteria were adults aged greater than 18 with clinical suspicion of acute poisoning with decreased GCS of less than 8, and excluded if the patient was pregnant, incarcerated, immediate needs of tracheal intubation, signs of respiratory distress, any clinical suspicion of brain injury, seizure, or shock. And shock was defined as systolic blood pressure less than 90 after 1 liter of fluid, signs of respiratory distress or hypoxia or more, SpO2 less than 90% with spike nasal cannula, or after an hour of nasal cannula, suspicion of any cardiotropic drug poisoning or single toxic substances that can easily be reversed, such as opioids or benzos. Because I think we all know with those populations, Narcan and probably we need to think at least with opioids. So the primary outcome that they looked at was the hierarchical composite endpoints of in-hospital death, length of ICU stay, in-hospital death, truncated at 28 days. So they followed at 28 days. Secondary outcomes that they looked at were proportion of patients receiving mechanical ventilation until discharge, number of days receiving mechanical ventilation, and the proportion of patients admitted to the ICU or with rapid onset pneumonia, which they looked at, I believe, within 48 hours of the chest radiograph, and then any adverse events from intubation itself. Intubation was up to the provider on what method, whether DL or video laryngoscopy, whether they use stylets or Brucey's, like that, and then we'll get to this else there. As kind of the breakdown. Kind of 237 patients were randomized, with 112 in the analysis on the restricted intubation group and 107 in the control group. this is kind of the initial part of the differences between the group. Pretty well balanced, young population. Most of them included within the emergency department or the pre-hospital setting. Most of them pretty stable from a vital standpoint. And GCS mean scores were around 3 to 7 in both trial ranges. And then the toxins, mostly alcohol, mostly mix of benzodiazepines or neuroleptics, and then less of like TCA, SSRIs. Kind of population, I'm not sure. I mean, it's basically they did a urine drug screening, alcohol level, popped up positive afterwards. And then at the bottom, you can see around 19 patients in the study arm ended up being intubated, while around 63 in the control group were intubated. And then get to our outcomes. No deaths in either one. Great. Or in hospital deaths, admissions to the ICU. As you can probably imagine, in the restricted intubation group, less number get admitted to the ICU. And then time, median length of ICU stay, pretty darn low. In the restricted intubation, a good 24 hours in the control group. And then hospital stay kind of also reflects that decreased length of hospital stay. Ample ventilation, 21 to 65. And then looking at the secondary outcomes, we kind of see a little bit more interesting things occur. Occurrence of pneumonia, only around 6.9% in the restricted intubation group, with 16 patients in the control group getting pneumonia. And then adverse events between the two, the arm with more intubations had more adverse events from intubation, with a higher first pass failure. Interesting. And then this was in the supplement, kind of breaking down where these patients ended up being intubated and the cause for their intubation. Majority, pre-hospital setting or the emergency room for the control group, but pretty even for when they arrived at the ICU. And breakdown for the cause of intubation. The majority of the control group was routine practice, because that was their decision choice. While the intervention group, less of routine practice, more from respiratory failure or persistent concerns there. Okay, so the results, kind of if we look there, so this was a pretty good trial. Good number of patients in both arms. It's much better than the 30s, 270s that were done previously. It was prospective randomized control. It, of course, it's unblinded, and it was known whether you were in the trial setting. So there's always a chance for the Hawthorne effect, where you're being studied, so we can practice in a different sort of way. The length or the improved outcomes that they were looking for, as they stated, there was no deaths, but it was largely driven by decreased length of stay in ICU for composite scores. And other weaknesses that they've kind of touched upon is like the majority of the population that they were looking at were things from alcohol intoxication plus kind of benzos. Those were the majority of their patient population. So in the previous trials, they're marking on, especially the organic phosphate ones, they didn't, or none of these patients received decontamination protocol either, so they weren't just like GI times. And then, I think it was some patient-centered outcomes were involved. They said it's a positive, some that I guess did address patient-centered outcomes. Detractors of this, say there were no patient-centered outcomes. It was just kind of length of stay driving the benefit that they showed. So questionable there. So that's about it from the discussion standpoint. So how does that affect us? I would say we probably don't. We usually get the receiving end of some patient population. As they mentioned here, the majority of these cases were intubated in the pre-hospital setting or in the emergency room. Brain also has some of their hospitals, if a patient is intubated on transport through EMS, they are directly admitted to the ICU. They bypass the emergency setting. I think it's just kind of reinforces what we've been saying, that GCS is a tool, but that's it. It shouldn't be used to drive, or it's just part of the decision making for whether or not a patient needs to be intubated for airway protection, particularly in the setting of alcohol or benzos and opioids. And I think we do a pretty decent job kind of reflecting on that, saying like, yes, we get consult before patient with GCS and fine. But that doesn't mean necessarily that they need to be intubated for airway protection. I think it's also interesting that there are higher rates of pneumonia in the control group than the trial group. Interesting today, because one of the main reasons that the proponent for intubation is this aspiration risk. And it's particularly when you relate that PCS less than a certain number is associated with loss of gag reflex and cough and all that. Can't we use this in practice? I think so. Maybe a couple of times per month, we'll get a pretty sleepy alcohol withdrawal. And they're still could be out of the GCS. Say it's pump the brakes a little bit on just intubating them. And then I think this will probably have a much greater impact in the emergency department world. They're probably seeing this patient population a lot more than we are.